Ladies and gentlemen, good afternoon. It's my great pleasure to chair this interesting session on smoking in the context of COVID-19 pandemic. First of all, I'd like to congratulate the organizers and especially Ignatius, and I think we have the chance to have two excellent physicians in the field of tobacco use. And first, let me introduce Dr. Farsalinos, who is going to talk about the tobacco use and the risk of COVID-19. Dr. Farsalinos, I think within 15 minutes you should, I think you will be able to conclude. Please, we can hear
Yes,
you.
thank you very much. I'm going to talk about tobacco use and the risk of COVID-19, mainly focusing on diagnosis. Professor Toumbis is going to talk about the risk of severity of COVID-19. It's a bit of a mixed findings. It would be too much to present everything in one presentation, but I think it's quite interesting. First of all, we know that smoking increases by far the risk for respiratory infections. I have several data here for pneumococcal infections, but the same thing is happening also with viral infections. The risk is much higher when someone is smoking. It also depends on the amount of cigarette consumed daily. And of course, we see a decline when people quit smoking, although again, it takes a long time since quitting in order for the risk to decline considerably. So we were expecting, and that was the original communication last year during spring 2020, that smoking or even other types of inhalable products like vaping would increase the risk for developing COVID or the risk of severity of COVID and complications related to COVID-19. But our original and my original findings when I analyzed some studies case series basically coming from China, what was, I would say impressive, paradoxically impressive, was the very low proportion of smokers who were hospitalized for COVID-19. And these were all studies coming from China. And we know that China is a country with a very high prevalence of smoking. It's about 30% in the whole population, but it's very high among males and very low among females. So more than 50, 60% in some age groups of males smoke in China. You know, there are about 1/3 of the world smokers are Chinese. So you understand that smoking is quite a tradition there. But the proportion of those hospitalized with COVID who were smokers was quite low when you compare that to the population smoking prevalent. And we went even further and we measured the prevalence odds ratio, which is basically a comparison between the gender and age adjusted smoking prevalence in the population and the smoking prevalence among hospitalized COVID patients. And it was quite low. Basically, what it says is that about 1/4 of the expected proportion of hospitalized patients were smokers. We were expecting 4 times more smokers to be hospitalized for COVID. And that was quite impressive. But that's not only our finding. There are several other studies, for example, here in Israel, an analysis of the largest social insurance in Israel, public social insurance, which measured basically the risk of being diagnosed with COVID. And they found that current smokers were about 50% less likely to be diagnosed with COVID, which is pretty unexpected because you would expect these people to be at higher risk. And not only there, in the UK, another very large data set of, I think it was 8 million people. And what they found was that heavy smokers, especially, were less likely to be diagnosed with COVID. And in that study, they were also less likely to be admitted to an ICU because of COVID. But I think that a large part of that was because they were not diagnosed with COVID. Another study, once again, now from, if I remember well, from Germany. from Essen, the town of Essen. They also found that people who smoke more than 10 cigarettes per day were 72% less likely to be diagnosed with COVID. So we're not talking about severity of the disease once they develop COVID, but it's about diagnosis. In Korea, the same thing, a lower risk of being, no, this is Chile. In Chile, they did an analysis of seroconversion among healthcare professionals, and they found that smokers were less likely to have developed over time antibodies for SARS-CoV-2, which means that they were infected and they were seroconverted. This is from Korea, which once again showed a lower risk for SARS-CoV-2 infection among smokers compared with non-smokers. So, we went further and we published studies of 20 and in some cases more than 30 different studies and meta-analysis, and we were still finding this underrepresentation of smokers among hospitalized patients. So much lower proportion of hospitalized smokers of hospitalized COVID patients were smokers compared to the population smoking prevalence, even when you adjust that by gender and age, because we know that older people, in older people, the smoking prevalence goes down. But does it mean that smoking is protective? Of course, it doesn't mean that smoking is protective, and you can never use smoking for any kind of preventive or protective role for any kind of disease, because we all know the very adverse effects of smoking. But what does it tell us? Is there any useful conclusions if those findings are the case? Because let's not forget that all these studies have limitations. And one of the limitations is that during a pandemic, you can't focus on one marker or one risk factor alone, so you cannot have a perfect recording of the smoking status. So without forgetting the limitations, even if we assume that all these findings are pretty accurate, then there is the issue of what to do with these findings. Well, what we did with these findings is we created the hypothesis that something is happening with nicotine that may be protective. And of course, that doesn't again mean that we should use smoking, but there are pharmaceutical products, and not only nicotine, but cholinergic agonists in general, which may have a therapeutic value. So when we analyze the structure and the amino acid sequence of the spike protein, we found an area which is within the receptor binding domain, but next to the receptor binding motif, that looks very much like snake venom neurotoxin, and in terms of the amino acid sequence. And we know very well that snake venom toxins bind to nicotinic acetylcholine receptors, and they compromise, they have an antagonistic effect on nicotinic acetylcholine receptors. So we went further and did some molecular docking and modeling studies, and we found that it is possible for the virus to interact in that area with the nicotinic acetylcholine receptors. Of course, these are experimental computational models. They are not clinical or even in vitro preclinical studies, but we created the hypothesis that there may be an implication of the cholinergic anti-inflammatory pathway. This is an anti-inflammatory pathway that was discovered in 2000. There are several publications in Nature and other big journals, basically by Kevin Tracy and his group in the US, which is a pathway that controls and provides immune homeostasis, so it can up or down regulate the immune response in order to have a certain balance through a central mechanism using vagus nerve through the brain, and by using alpha-7 cholinergic receptors, which are available everywhere in the human body, I mean literally everywhere, including in immune cells, including in epithelial cells, bronchial epithelial cells, everywhere. So this is a mechanism through which the immune response can be balanced. And since we know that COVID-19, and especially the severe form of the disease, is basically a sort of a form of cytokine storm, a sort of hyperinflammation and an imbalance and a dysregulation of the immune response, we made the scientific hypothesis that there may be something wrong with the nicotinic cholinergic, the cholinergic anti-inflammatory pathway through the action of the virus on the alpha-7 cholinergic receptors, and this creates that sort of an imbalance. And by protecting the alpha-7 receptors and restoring the function of the cholinergic anti-inflammatory pathway, we may see an improvement. And we did some additional molecular modeling studies, and we also analyzed not only nicotine, but other cholinergic agonists, including varenicline, for example, which is a smoking cessation medication. And we found that there may be some interactions on a computational models between these compounds protecting the alpha-7 cholinergic receptor when compromised by the virus. And what happened recently, a couple of months ago, is that our scientific hypothesis was verified in vitro and in vivo in monkeys, in experimental animals, using two alpha-7 cholinergic agonists. One is indeed varenicline, and another one is a proprietary alpha-7 cholinergic agonist by this company, which is a pharmaceutical company in the US. They did in vitro studies in bronchial cells and in vivo studies in monkeys, and they found that the viral load is reduced significantly when these compounds administered compared to placebo. So it is quite an interesting hypothesis, which is still evolving, of course. And I know, since we are in contact with the company, they contacted us, that they want to proceed with a clinical evaluation of this hypothesis. So in conclusion, the data with the limitations, and there are several limitations, show that smokers seem to be less likely to be diagnosed with COVID-19, and fewer smokers than expected appear to be hospitalized for COVID. But I'm sure, as Professor Toumbis will show, and we've also published that once hospitalized, smokers have a much higher risk of developing severe COVID-19 or even dying. This is also our finding. So there is some sort of a mismatch between being diagnosed and then having severe COVID. These findings, of course, do not support any role for smoking, but they do support the hypothesis of pharmaceutical intervention in relation to cholinergic agonists, which, of course, we don't know yet if it is clinically valid. So we need to wait for clinical studies in order to verify our hypothesis. So that's my presentation. Thank you very much.
Thank you very much, Dr. Farsalinos. Excellent presentation and very interesting hypothesis. Now I think we should move to the next presentation by Dr. Toumbis. Dr. Toumbis is a pioneer in the field of smoking cessation in Greece, and he's going to give a talk on tobacco use and severity of COVID-19. Dr. Toumbis, you have 15 minutes, please.
Okay, thank you very much. My presentation concerns the smoking severity of COVID-19. Of course, the COVID-19 pandemic has imposed on human a new way of life, a new way of living with health consequences. Here we have the newly reported and cumulated COVID cases by WHO region as of 29 August 2021. As you can see, until now we had about 215 million of cases and about 4.5 million of deaths. On the other hand, you can see the estimated smoking prevalence today As you can see, there are many areas of the world with high prevalence of smoking. And it has been estimated that today the smokers are about 1.1 billion. So it is logical to see the consequences of this relation between smoking and COVID-19. As you can see here, the prevalence of smokers among COVID-19 patients using the REM, it is variable in several areas of the world. China, for example, 9%, USA 20%, other 19%. Anyway, this is covered by Dr. Farsalinos. Here you can see the various, the range, the spectrum of COVID-19. You can see that there are 3 stages, stage 1, stage 2, and stage 3. Stage 1, in stage 1 include the infection with SARS-CoV-2. In stage 2, the symptoms emerge requiring an outpatient visit or hospitalization of 24 hours or more. And in stage 3, disease progression becomes so advanced that it requires ICU admission or mechanical ventilation or results in death. For each stage, there are several questions. The first 2 questions, I believe that Dr. Farsalinos covered them. And my presentation has to answer the 3rd question, why the disease progression, if the hospitalized smokers are more likely to suffer more or worsen outcomes from COVID-19. And in order to have a general picture, here you can see the prevalence of severe of hospitalized COVID-19. It is low, fortunately. The estimate effect is 0.29. And here you can see, in order to have a general picture, sorry. Here we have from 12 cohort studies, including 2,500 patients with COVID, you can see that the risk factors for severe disease is several comorbidities, including COPD, diabetes, coronary heart disease, stroke, arterial hypertension, malignancy, and smoking, which has an odds ratio of 1.7. In a review and meta-analysis of 13 studies with 3,000 patients with COVID-19, we see again that for severe and very severe cases, the odds ratios, again, smoking in among the risk factors with an odds ratio of 1.79. And with other, and of course, with several other diseases that are closely correlated with smoking, such as COPD, coronary heart disease. And here we have the mortality. There are several factors. Smoking again is 2.70, so 50. And here we can see survival curves. As you can recognize, the smokers had a worsened survival than no-smoker, which give us a wrong rank of less than 0.5 and an odds ratio of 1.9. So I'm going forward in order to present you about 6 systemic reviews and meta-analysis, which are going to give us a clear answer to our questions. In the first, we have 47 studies included in this systematic review, with a total number of hospitalized patients about 33,000, and in 94% of the studies, the smoking status was defined. Here you can see that the current smokers, the current smoking has a relative risk of severe COVID 1.80, and for severe and critical COVID 1.98. The overall prevalence of current smokers in these studies was 6.2%. But after a sensitivity analysis, these findings were become non-significant. As also, and for this, as you can see here, the relative risk for disease progression, ICU admission, mechanical ventilation, and mortality in current smokers are not significant. But in patients with a history of smoking versus never smoking, you can see that the relative risk are significant. For disease progression, the relative risk is 2.18. For severe disease, 1.31. For severe or critical disease, 1.35. And the need for mechanical ventilation, 1.20, and mortality, 1.26. So the conclusions of the authors were this, that the current smoker had an increased risk of presenting to hospital with severe COVID and were approximately twice as likely to experience severe or critical COVID as former or never smokers. For the smoking history, the patients with a history smoking, there was an increased risk of presentation to hospital with severe as well as severe or critical COVID and subsequent increased risk of in-hospitalization mortality. Additionally, the patients were more likely to experience disease progression and require mechanical ventilation. Let's move now to the second meta-analysis, second review and meta-analysis. Here we have 19 peer review papers with about 11,500 patients, and the outcome were progression to more severe or critical conditions or death. Here we see that 18% of the total number of patients have had progression. Patients with smoking history, we have 17.6, and in patients without smoking history, 6.3%. The meta-analysis of these findings shows that there is a relative an odds ratio of 1.91. And this is a significant finding. And in analysis of current smoking and COVID progression, in studies with current smoking and COVID progression, the odds ratio remains the same. In a second meta-analysis and review of the same authors with 47 papers, and with a total number of patients of about 23,000. Here you can see that patients with progression were 23.6%. Among the smoking history, among the patients with smoking history was 32.5%, and among the patients without smoking history, 21.1%. This gives us an odds ratio of 1.59. Furthermore, the progression of current smoking versus never smoking give us an odds ratio that wasn't significant, was inconclusive. Former smoking versus never smoking with odds ratio 2.2, ever smoking versus never smoking, mortality 1.19. So, and furthermore, ever smoking versus never smoking and age has been found that a decrease, we have a decrease by a factor of 0.78 per 10 years. Here you can see the diagram, the slide with this finding. As you can see, as the mean age decrease, the odds for disease progression increased. So, sorry. The conclusions of these two studies were that smoking is an independent risk associated with severe progression of COVID-19, including mortality. The effects seem to be larger among former smokers, and younger smokers, less than 50 years, appear to have a higher risk of COVID-19 disease progression than older smokers. Let's move now to the fourth preview. Disease severity give us in smoking history odds ratio 1.55, in former versus current smoking 1.85, and current versus never smoking 1.19. And admission to ICU give us an odds ratio 1.73, composed endpoints 1.69, and mortality 1.58. So there are these geographical assessments. As you can see, smoking history with disease severity. In China, the odds ratio was 1.81. In USA, it was 1.43, and in other areas of the world, 1.47. And of course, there are variable covariates that affect these associations. So in conclusion, we have the same almost conclusion. The smoking was associated with severe disease or critical outcomes. The association was more significant for former smokers than in current smokers. Current smokers also had a higher risk of developing severe compared to with non-smokers. And there was a geographical variation of the smoking and severe disease association. Here we have a living rapid evidence review, and you can see that the current smokers versus never smokers give us a relative risk which is not significant, which is not conclusive, and for former and never smokers, the relative risk is significant, 1.2. The same is for current versus never smokers for severe disease. You can see that the relative risk for the current versus never, it is not conclusive, but for former and novice smokers is conclusive. And finally, the risk of death, again, the current versus never smokers is conclusive, and in former versus never smokers, it is significant, 1.39. So, and I will finish with this review. Here you can see that we have 40 studies and 370,000 patients. You can see that the current smoking versus never smoking had an odds ratio for severity 1.78. For former was 2.48, 2.54 for former in patients higher than 65 years. You can see that in former patients, the odds ratio was almost double compared to the current smokers. And here again, we have for death, again, the same, the odds ratios are increased, but in former patients, in former smokers, the odds ratio is almost double. So let me move to my conclusions. There is a lower prevalence of smoking in COVID-19 infected patients, of course. But both current smoking and former smoking significantly increase the risk of disease progression, severity, and mortality. The current smoking is less likely to have negative outcomes compared with the former smoking. And there are several explanations. First of all, the underreporting of the current smoking. And second, the former smokers have longer exposure period or accompanying diseases. So, of course, in one review and meta-analysis, it has been found that younger smokers appear to have a higher risk of COVID-19 disease progression than older smokers. And there was a geographical variation of the smoking and severe disease association. So well-designed population-based studies that control for age and relevant underlying risk factors are needed, and further occasional studies of this association and for the underlying mechanism of this relation is warranted. Thank you for your attention.
We thank you very much, Dr. Toumbis. I think you made clear that smokers are doing worse. They have more hospitalizations and higher mortality with COVID, and your message was clear. I don't think we have any more time for more discussion, and I don't think anything in the chat. We thank you both for the excellent presentations. We thank the audience, and we have to proceed with the next session. Thank you very much.
Thank you very much.